Welcome everybody, and would like to welcome you all in this monthly pediatric dentistry gathering by the Saudi Society of Pediatric Dentistry here in Saudi Arabia. We are honored to have two distinguished speakers this night, Dr. Laree Johnson from United States and Dr. Mazin Al-Qahtani from Saudi Arabia. Both are distinguished speakers, and I'm sure we will learn a lot from them tonight. Our first lectures will be by Dr. Laree Johnson. Dr. Laree Johnson graduated with an honors from University of Tennessee College of Dentistry before completing a 3-year pediatric dentistry residency and a Master of Science from University of North Carolina. Dr. Johnson was part of the American Academy of Pediatric Dentistry, Kellogg Leadership Institute, Cohort 5, and served as adjunct faculty at the University of North Carolina. She has been inducted into the American College of Dentists and International College of Dentists, and she has served as the president of the North Carolina Academy of Pediatric Dentistry, and she is the current president of the American Board of Pediatric Dentistry. She has been a full-time private practice, in full-time private practice for 22 years. She's the founder of the Carolina Pediatric Dentistry, a multi-doctor 2-location practice in North Carolina, and speaks nationally and internationally. Foremost enjoys the clinical pediatric dentistry. Her effective practice management skills are simply a byproduct of ensuring a patient-centered practice model. Being a wife, a mother of 2 teenagers brings Dr. Johnson her greatest joy. Her family enjoys travel, CrossFit, and endurance sports. Dr. Johnson and her husband have completed multiple Ironman triathlon. So we would like to welcome her in a very interesting lectures about the clinical implications of MTA in pediatric dentistry. So welcome, Dr. Johnson.
Thank you so very much. And there's a few people here in the US that just want to come jump in the camera and say hi before I get started. Some of the team members, this is their lunch, so they're just kind of waving in and saying hi from our side of the world to yours. And thank you guys so much for having us. All right, without further ado, and thank you so much for that kind welcome. You know, for me, my passion to be a leader, to be the president of the American Board, stems from having alignment with the mission of the American Board of Pediatric Dentistry, and that's to promote positive clinical outcomes for children. And I believe that's also in alignment with your organization as well. So I'm happy to be here. In addition, I'm very excited to talk about MTA. This has been a game changer in my practice for well over a decade. And I'm also happy to partner with New Smile companies similar to the board, similar to you all. They do have a passion to promote positive clinical outcomes for children, and they constantly strive to improve their process as well. So as you can see, this is Neo MTA 2 and Neo Putty, which are actually the second and third products that I've used from MTA. I used to long time ago use ProRoot, but it turned the teeth dark, so we don't do that anymore. So without further ado, let's kick this off. We have a lot of exciting things to cover, and I'm watching my time very carefully. All right, so to begin, just want to let you know that there's 3 things that I look at when discussing pulp therapy. And I break it down by AIM. The A is for assessment at multiple diagnostic points. When we're interacting with the pulp of children's teeth, and we'll get into more detail later, we want to make sure the most important key is a proper diagnosis, whether it's a reversible pulpitis or an irreversible pulpitis. The second, which I feel is so terribly overlooked, is isolation. And we definitely need to ensure we have adequate isolation to ensure we don't cause contaminants to be into the pulp chamber, and that we set the teeth we're treating up for success. And then finally is the meticulous placement of the medicament. And I'm going to actually show you an x-ray a friend sent me last night about why his pulp was failing. And we need to understand that we need a perfect seal between the pulp material and the pulp tissue. If it's not touching the pulp tissue, we're not going to have the biological effects that we're desiring, and we're also opening up space for bacteria to grow. And then finally is a quality restoration. And that's not what I'm here to talk about today, but I'm going to give you a couple tips to make sure we're setting your pulps up for success. Okay, so the first thing just to talk about real quick, back to diagnoses, just a couple cases to show you. This is a child that was referred to me because the general dentist felt they needed extraction of tooth F due to an abscess. And of course, when you look at this, you can say, well, that child has had trauma. There's no doubt about it. There's atypical resorption. There's something going on there. But when you re-image this child, what is very obvious is that is just a superimposition of the nair. And children move a lot, so you often don't see the equal distribution of the nairs as you do on the film that I retook. And of course, these teeth were fine and not abscess and did not require extraction. The second thing to show, this child was referred to us to actually restore facial caries on both E and F. And of course, this is not the right choice. This is a situation of trauma, but this is external root resorption. So the last thing we would want to do is restore a tooth that is basically on its way to abscessing or resorbing to be lost early. Similarly but different, these teeth all have caries, and I often see this on social media, and it's so alarming to me because people think they can treat these teeth, and they remove the caries and they're not into the pulp, and they're masking this dark presentation. Of course, what we know is these are necrotic pulps. The literature tells us when you have a gray tooth, 97% of the time it's a necrotic pulp. And I would go to say, I believe it's actually 100% of the time. So if we restore them, it might look beautiful, but then if an abscess develops on the teeth, the parents, of course, are going to blame us for the abscess. So in situations like this, we need to, of course, do a pulpectomy. Similarly but different, these are teeth treated with SDF, and you can see the discoloration, but this is not due to trauma. This is not a necrotic pulp. This is just leaching of the silver diamine fluoride. And of course, these can be restored without treating the pulp, as long as, of course, they're not into the pulp. And these were all indirect pulp caps. Speaking of SDF, just want to take a moment. This is a severely medically compromised child with cleft palate that was referred early and was not well enough to go to the OR. And you can appreciate the root walls are so very thin, not a candidate for a pulpectomy, that's for sure. But we applied SDF at multiple visits until his health was stable enough where we could go to the OR and actually save these teeth. So something else to remember, sometimes we don't need to get into the pulp. Sometimes silver diamine fluoride is the answer, and sometimes an indirect pulp cap is the answer. And we'll talk more about that. So let's talk about indirect pulp capping for just one moment. And I'm going to show you an example clinically of this before our time together is over. For indirect pulp capping, even though I primarily use Neo Putty, I do not use it for indirect or direct pulp capping. And the reason is I like a thickness of the putty to prevent washout. And it's hard to put a very thin layer of the putty, where with the Neo MTA2, you can place a thin layer, place Vitribon over it, and it'll stay, and you can restore it with composite. You can restore it with a crown. You can do whatever you need. But of course, we only do indirect pulp caps on asymptomatic teeth, never symptomatic teeth. And this even means for me, if I have a situation on a primary molar where it hurts with eating, as in sweets or something like that, I will do a pulpotomy. But if I'm restoring a tooth that is asymptomatic and I can avoid the pulp, I will do an indirect pulp cap by placing Neo MTA2 and then Vitribon over it. And I will show you this later. So this is the pre-op film. And then this is this child 1 year later, and then two years later. And what we know from evidence-based dentistry is that these have an equal success to pulpotomies. The key is the diagnosis, as I'll go back to so many times today. So direct pulp caps. So for me, in my hands, a direct pulp cap is going to mean a trauma. Every time it's going to mean a trauma, because if I have caries that are asymptomatic, I'm going to do an indirect pulp cap. If I have caries that are symptomatic, but reversible, I'm going to do a pulpotomy. And of course, if it's an irreversible pulpitis, it's going to get a pulpectomy as a primary tooth or a root canal as a permanent tooth. So direct pulp caps are almost always trauma in my life. And it can be a trauma that, you know, even though we always use mouth props, pillows as we call them, a child pushes the pillow out and causes a trauma from the burr, which is very uncommon, mostly a trauma that they've had at their house that they come to us with. But for the direct pulp cap, what we're going to do is place the MTA, again, cover it with the glass ionomer. I use Vitribond. We're going to go, if I'm doing a composite, I'm going to go to the composite, and with every single composite that happens under my hands, after I complete a composite, I always finish it, re-etch it, and then I place a sealant after. And the reason why I do this is we know that most failures with composites occur at the cavos surface margin. And if there's any microvoids, I want to catch them initially. If I use doing posterior teeth, I'll use ClinPro. If I do anterior teeth, I'll use Delton Clear Sealant. And there's my sealant on top. So just a real quick, I think we all are very familiar with the history of pulpal medicaments. And I'll just give you a quick rundown. I've been practicing a long time. I've used a lot of this. I was trained with formocresol, and it works extremely well. I remember vividly the day I stopped using formocresol. I was a brand new mom back from maternity leave, and I spilled a bottle of formocresol on the counter, and it ruined a countertop. And it smelled horrific to me, as it did during my pregnancy. And I really took a hard look at, would I put this inside my child's tooth after seeing how it eroded a countertop? And the answer was no. So at that time, I actually switched to ferric sulfate, which had horrible radiographic success, but reasonable clinical success. I used sodium hypochlorite for a while, which was reasonable success, but not ideal. I trained with laser and electrosurge pulpotomies, but they mask, the diagnosis masking is a real concern there. Not ideal. And I have not used glutaraldehyde, and I don't use calcium hydroxide, but I've tried all the others. But the key is nothing is as effective or predictable as MTA, and that's why we're talking about it today. So as I mentioned, I use Neo MTA2 for direct pulp caps and indirect pulp caps, and I use Neo Putty for all pulpotomies, whether it's permanent teeth, a spec due to trauma, or it's a regular pulpotomy or a primary tooth. So why is MTA bioactive? Well, when we add water to it or gel, if it's Neo MTA, what happens is that calcium hydroxide within the cement matrix is formed, and it's extremely basic, and it's this high pH of 12 with calcium hydroxide that causes precipitation of calcium phosphate on the surface of the MTA, covering the entire MTA surface. This is why it's so important it touches the pulp tissue. So the body recognizes that, and the calcium phosphate layer, when the body recognizes that calcium phosphate layer, it begins to form hydroxyapatite, and that is what promotes the dentinal bridging, which is what we want. So I'm going to show you a posterior trauma, and incidentally, I see these all of the time. So this child went down the slide, fell, really had a deep laceration in their chin, went to the ED, had stitches. The ED, the emergency department, looked at their teeth and said, teeth look great, don't worry about the dentist. But then a week later, what happened, let's go back here. A week later, the tooth actually separated, and then the parents brought them in, and you can see this traumatic pulpal exposure on this tooth. And oftentimes these are non-savable when they happen, but in this situation, we completed an MTA pulpotomy, and you can see this image from 2 years later, this gorgeous dentinal bridging beneath the MTA because it made contact with the actual pulpal tissue. And I'm just going to run through this technique really quick with you all. So this is actually a friend we saw recently in the practice. This child, another provider, started with a class 2 composite that got recurrent caries and ultimately fell out. So with the way I start is with the football diamond. You'll see this in a minute. I reduced the occlusal of tooth. I did a little bit of minor interproximal step through. I moved to a slow speed burr, and there you have it. You can see my pulpal exposure. Now, what's real important is I don't remove interproximal caries at this point because I don't want that contributing to blood that might be mistaken as pulpal hyperemic pulp tissue. So I focus on the pulp and leave that area to the end. I then pick up that football again, unroof my chamber, take the slow speed and remove the pulpal tissue, pack it with pellets, and then this is what it's going to look like after the pellets come out. And then I move to the MTA and put it in there. Now, something important, when I extubate the pulp with my slow speed round burr, usually a 6 or an 8, I use copious irrigation. Some people, for example, in the OR, use sterile water. In our office, we treat the water in our self-contained units, so I know I'm not introducing bacteria. I don't go in with any other sodium hypochlorite or any other medicament after the cotton pellets. And these are sterile cotton pellets. We sterilize them. I move straight to the MTA. Then I remove the caries interproximal, and then, of course, the final restoration. So what are the things that are the same between Neo-MTA2 and Neo-Putty? Well, they're both bioactive, bioceramic MTA. They both promote this hydroxyapatite formation support healing. They're both extremely high in pH, and the basicity is antimicrobial and promotes dental repair, and neither of them wash out. The differences between the two, the Neo-Putty is a little bit more radiopaque. The Neo-Putty does not start setting up until it interacts with either water from the dental or fluid from the dental tubules or the pulp, and it is much less waste, so it's much easier to mix. It saves a lot of money once you train your team. So the keys again to pulpotomy success, and I would say isolation is definitely a key, and then ensuring that you're going into this with it's a reversible pulpitis. It's not an abscess tooth. It's something that you can treat. Then when you open the chamber, you're going to take another look. Is there pus in the chamber? If there's pus in the chamber, that's probably not a tooth you're doing a pulpotomy. If there's just a little bit of necrotic tissue, but when you extirpate the chamber, it's okay, maybe so. You'll have to see. And then after you remove your pellets, is it fast to bleed? Is it hyperemic? That's probably not a good candidate for a pulp either. Then you want to make sure that MTA is against the pulp tissue. You're not gently setting it there. You're pressing it against the pulp tissue and finishing with a quality restoration. So is there anything you can't do with MTA for the pulp and primary teeth? And the answer is yes, it's necrotic canals. You do not want to fill a canal with MTA because it's not resorbable like ZOE. You'd want to use ZOE or something else for that. And I'll show that to you. So oftentimes, and I don't know why when we train, you either do pulpotomy or you do a pulpectomy, but the reality is oftentimes not all the canals are actually necrotic. You don't need to instrument all the canals. So this is a situation where we did a partial pulpectomy, I guess you could say, and we did fill the necrotic canal with ZOE, but we put Neo-Putty over the vital canals, and you can do that, or you can just use ZOE if you want to do that too, to make sure everything's good, but you can actually do both, and that's perfectly fine, and if a child is in the chair, it's quicker for them to do it this way. This is not my work. This is a good friend of mine who uses Vitapex. He loves atypical morphology and he loves doing pulpectomies. This is certainly a fair solution, but I personally, I don't like calcium hydroxide in primary teeth. I haven't had great luck with it, but I thought this would be interesting to show you. All right, real quick recap of a clinical study. So this is comparing MTA to calcium hydroxide. And of course, I, for many years in my practice, use calcium hydroxide, but this is actually doing pulp capping on permanent teeth with carious exposures. And as you can see, MTA is superior, and it's superior in every way to calcium hydroxide. So permanent pulpotomy. So this happened during the first COVID, the first month of COVID lockdown. This is not my patient. S&T are not my work. And this child is also on the autism spectrum. Very difficult friend to take care of this day, but he had this severely hypomineralized tooth, and he had tooth pain when he ate sweet and other things, so he needed treatment. So we anesthetized him, and the pulp, it was a very, for lack of better words, mushy tooth that I could not keep out of the pulp. So we completed an MTA pulpotomy, and he doesn't allow us to get x-rays, but this tooth has been asymptomatic and remained vital, and the apices, I'm assuming, are closed because there are no symptoms and he's doing well. Now, normally when I do a composite that's this big, I would choose to put an orthodontic band to support it until he can have a definitive crown when he's older with a general dentist. But this family was not in favor of the orthodontic band because they had had stainless steel crowns and they believed it contributed to his autism. Here's another situation. This is a child we saw, again, toothache with eating sweet was the issue. So we completed this pulpotomy. Well, we completed the entire quadrant. And you can see this is the cotton pellet stage. And when I removed the cotton pellets, it was a bit more hyperemic than what I ideally like to have. So I actually took the burr down to where I felt I had healthy tissue a little bit more. And you can see this is after, of course, the neo-MTA and then covering it with Vitribond. And you can see I took it a little further past the CEJ than ideally I would like to do. But again, this tooth is asymptomatic. The child's doing extremely well. And you can look at the apices, and that is thickening from the sinus. You can see the tooth in front of it's very similar. But this child's performing well. And I have sent this x-ray to an endodontist and said, hey, what do you think about this? This is going to make you hard to instrument if you have to do a root canal. And they said absolutely not, that some people will take MTA to the mid-root. Of course, that's never going to be my intention. All right, I want to talk about isolation because I feel it's so incredibly key and people overlook it. We are very serious about isolation. Even if it's a partially erupted tooth, we'll get a little bit of a gingival bite to set a permanent tooth up for success for the rest of this child's life. We double isolate quadrants. We do use isolite for sealants in our practice, but we primarily rely on raincoat isolation with ligatures. And I'm going to show you how we do a ligature because some people, they haven't seen these. And just to show you, I tried to go slow in this video. So basically you just take it, turn your hand and grab one side of the ligature. It's the super fast way. You can do it the slow way of making a knot, but that is the fast way to do it. And this is what we do on a routine basis here. It's not wanting to leave my video. Let's see if I can. There we go. So this is a little guy. This is a fresh 3-year-old that we treated. You can see how we use ligs to produce and freehand composites, a key experience. All right, I'm going to move on to treating with Spec Pulponomies from traumatic exposures. So this is a child who was, believe it or not, jousting on his bicycle with his friend who was on his bicycle using tennis rackets like they were medieval knights. And of course, that did not sort out well. We had 2 traumatic exposures and we had 1 fragment. And I'm not going to tell you what side so that we can look at this together. So this is initial film. You can't appreciate the pulp exposure from here, but we did Spec Pulponomies. I always ask for a photo before the injury to try to recreate that from the parents. So this is the photo they gave us. This is the pre-treatment image, and this is the directly post-treatment image. Why do I attach fragments? I think they look better and they make the process 3 times faster. So tooth 9, the left central incisor, is the fragment attachment. Here's another friend, same thing. Spec pulpotomy with neo-putty. One side, they found the fragment for one side. This is immediately post-op. Again, it was the left incisor that I was able to reattach the fragment, and the right incisor was free-handed. And this is 6 months post-op. So I'm going to show you how we do this because I get a lot of questions about it, and people talk about their specs failing. And I think it has a lot to do with the sealing of the tooth after the fact of the trauma. So I'm going to show you. So first of all, I had to break and extract a tooth. Of course, this is a necrotic tooth, and it's not going to look the same radiographically, but I did make an exposure. I accessed it, and of course, I put a pellet just like I would for teaching purposes. We used the Neo Putty. We put it in there. We covered it with Vitribond. This is the fragment side of this premolar. I removed the dentin from the fragment side. Then I made locks on the tooth side. I like inverted cones. 34 is usually my favorite, but you can use a quarter round. Then I put composite, etch, bond, both fragment and tooth, put composite, not flowable, regular composite, replaced the fragment, cured it, making sure that I did not touch the puzzle piece enamel portion. And this is what it looks like. There's going to be some voids where the little shards come off. From there, I normally am able to pack composite around those voids. If it's so little I can't fit it in there, I'll go to a Revolution type flowable composite or a Filtech. And then I take this burr. This is an important piece of the puzzle. This is why none of my fragments have ever come off ever one time in my career. I put this bevel around the junction of the fracture. And what that happens is where there was the tiny void where the composite didn't penetrate that enamel puzzle piece, now we're reinforcing it, but we know the fragment is exactly where it's supposed to be. I specifically did not do the lingual so that you could see radiographically the way this looks. So this is the way it appears facially with 0 voids, 0 areas for leakage where it might contaminate your pulp. In the lingual side, you can see the very small void, and that's because I did not put the bevel there and go back and reapply the composite around it before finishing and sealing over. And of course, this spec looks a little different. You need at least 2 millimeters of Neo Putty, and there's a little bit of leakage because this is, of course, an extracted necrotic tooth, but that's what it'll look like. You remove the dentin, so you have the highest bonding satisfaction from your composite from the fragment, and you have your 2 millimeters of your MTA covered by Vitribond. And this is what the tooth looks like when all is said and done. Okay, so just a couple things to talk about and we'll get started prepping some teeth. So this was actually literally last night. This is a really good friend of mine that was a dental student when I was a resident. I've known him forever. And he said, he sends me these pictures. He's like, why are all my pulps failing? And I felt really, really bad for him because he wants to do right for his patients, but there's a few things that are why his pulps are failing. Well, first of all, this tooth doesn't look like it had a pulpotomy. So he may have put MTA in there, but it's not actually touching the pulpal tissue. So he probably has space where bacteria can grow. Second thing, and the obvious thing, this is not an ideal crown fit. We're probably having distal leakage, and he's using Keetac cement to cement zirconia crowns, which is inferior. So he has this big, because Keetac's fine for stainless steel crowns where you can wash them thoroughly and clean them, but this is a big glob of Keetac cement on the mesial of this tooth, and it's caused vertical bone loss in that area as well. So these are really important things to learn. I'm just going to show. So this is another spec pulpotomy from a traumatic exposure that we did. And you can see the angle we came in, and you can see this tooth had the fracture line went this way. So you can see a little aberration on where the MTA traveled there, the Vitribond, and then again, the composite reattachment of that fragment. This is just a regular tooth treated tooth T. But this is what we want. We want our pulps to dip down into those orifices. The tooth will still exfoliate even with MTA with it dipping down those orifices. If you don't see that dip down in your orifice, you're not really engaging the tissue like you want and potentially opening up space for bacteria to grow. Here's another situation, and these are all conventional treatment patients. They've chewed on our films, as you can see. These are tricky characters. But you can see, again, tooth number T is treated, and then the way it looks, just dipping down the orifice just a little bit, really good adhesion. Okay, I am going to stop sharing my screen now, if I can remember how to do that, and we're going to do a little bit of clinical work. So I think we stopped sharing and we're going to switch to our webcam. over to our clinical webcam. And if you guys will bear with me 1 minute, I am actually going to put my loops on. So hang on 1 second. I'm going to put my loops on and then I'll be right back with you. All right. Okay, let's see here. All right. Can everybody hear me? Are we good?
Yes.
Okay, wonderful.
Yes.
Thank you for that affirmation. All right. And I just want to take a second. I want to point out two wonderful people. That's Darlene. She has been my right arm since I was a resident in '98. And there's Anita. She's been with me for over a decade too. As with any good organization, it takes a good team to make things happen. So what we're going to do, I'm going to take this into the real world scenario, and I'm going to prep tooth K. This is a gel infused pulp tooth. So I'm going to prep it just like I would in the practice, as if I was going to do zirconia crown, and we're going to treat it. And I'm going to keep a close tab on my time. So we're just going to start off here. You're going to hear the handpiece going, and we're going to talk through this whole thing. So when I'm doing a zirconia prep, Darlene's going to give me a little air, because we know these ivory teeth. The first thing I do is I just reduce. I'm not even playing around. I just reduce the occlusal surface. Now, we know a real tooth would have a little central groove here. We'd probably do that. The second thing I would do, I do not do those depth cuts anymore because I've done so many of these. What I do is use my football. This is my favorite burr on the planet. And I basically put a chamfer all the way around just to make sure I do a 45-degree, not a complete step through, but a 45-degree lightening of the interproximal contact. And then I put the chamfer on the lingual. Now, normally at this point in the real world, I would pick up my slow speed and remove the caries. Of course, this tooth doesn't have caries, but it does have a pulp. After I do my caries removal, if I deem it's not going to be an indirect pulp cap or anything or whatever the situation, I use that same football burr to remove the chamber. So obviously no caries on this tooth, so this is a little bit different scenario. But I just flip that chamber right off and access. And you can see these teeth are really lifelike. They're really just fascinating. Then, of course, I use my slow speed. Now, normally, Darlene would be using copious irrigation with the treated water. But in this scenario, it kind of makes a big mess. And this pulp is really nice. It doesn't quite behave just like regular pulp, and each one's a little bit different, but it's pretty close as you're going to get to the real thing. And again, normally she would be doing copious irrigation in there and making sure we get this. And this pulp, it kind of likes to stick to the burr and keep coming with us. Let's clean some of that off and go back to it just a little bit. Just make sure we get out. And we want direct access. We don't want any residual pulp tissue in there. We want to see, because sometimes that residual pulp tissue can really gum up your hemostasis, and you want to take it down to the orifice. So that is basically what that's going to look like. At this point, she would normally wash and dry, but she's going to hand me these sterile cotton pellets, which we are going to place in there. And I like to directly focus on one root of the tooth with some pressure, and then she will give me some more. Again, these are sterile pellets, and we will put those on the other side. And really, I take some time. If you're getting pressure hemostasis, you need a little bit of pressure. Now, if this tooth was truly an occlusal exposure, I would prep the exterior because I'm not going to have this leakage in, and I will do that in just a minute. But if it was interproximal, I would leave the interproximal caries and not disrupt this prep until I had the pulp controlled and was satisfied with it, much like the tooth beside it. What we're going to demonstrate now, though, I'm going to show you, we have this tooth, and of course it's an extracted tooth, so I can't see the pulp blushing. So we're going to play like we're doing an indirect pulp cap here. And Anita's going to mix up Neo MTA2 in a soft slurry, as if I were going to place an indirect pulp cap, or frankly, a direct pulp cap would be the same scenario. So I'm going to show you how she mixes that for that scenario. And she's going to come back to me for that in just a minute. So this is basically a soft mix. The mix is different. Again, if I'm doing a direct or an indirect, I'm not looking to condense it. I'm looking to paint it on the deepest portion, closest to the pulp, if it's an indirect, where it was deep, or if it's a direct, put it right on that pulpal exposure. And that would be, of course, a scenario of a traumatic exposure, whether burr mechanical, which happens once every 10 years, or trauma, which happens every week in our practice. And then she's going to bring it this way, and you're going to see how this mix is very different than the mix we use. And hopefully you guys, can they see that, Anita? And then I'm going to put it in just the deepest part. Again, this would be for example, a hypomineralized permanent molar. And that's all we want to put there, because I'm going to put a composite over this. Now what's going to happen is Darlene's going to come now with this Vitribond, and we're going to cover it with this, because what we want to do is, we've used such a little amount. We want to make sure that we cover a little bit there. And we want to cover the MTA in as little as possible, but make sure there's no margin of MTA showing. So it's going to look like that. And then of course we are going to cure it and make sure that that's set. So that would be how we would use Neo MTA2 for an indirect or direct pulp cap with a slurry mix. Now what we're going to do, I'm going to set this guy aside. Anita's actually going to mix for the regular pulpotomy for the tooth that we're doing. And while she's doing that, I'm just going to go ahead and quickly prep the tooth for the zirconia crown. And you can see when I'm trying to watch her, watch me do the same time, but what she's doing, the expensive part of MTA is the powder, of course. So she wants to use it judiciously. And she wants the mix to be very different than what it is for a direct or an indirect pulp cap. And again, if I had interproximal communication, I would not be doing this prep right now, because I want to make sure that I keep it pristine while I'm prepping without getting any gingival crevicular fluid into it. And what I was doing just then is taking just a couple cotton pellets out to ensure that I did not get it caught up in this handpiece, but leaving the pressure hemostasis where I want it. And she'll holler at me when she gets it just like she wants. Okay. Now I'm kind of nitpicking this prep a little bit. Okay. So she has her mix ready. I like to use an amalgam condenser. So I've done my little zirconia prep while she was mixing. So I'm going to take these pellets out. And you can see, obviously, the gel's a little messy, but what we don't want to see in a real world tooth is just hemorrhagic pulp, because then we know that's not the right answer. I like to take the condenser, much like the pellets, and focus on one side and really get it down on one side, because again, if you're not making contact with the pulp tissue, so I figure my friend, that image he showed me was bat. He just kind of dropped it in there and called it a day. We don't want to do that. Some people believe that if you compress it, it'll engage in the canals and the tooth won't resorb. You are not going to displace healthy pulp tissue. It's just not going to happen with a cotton pellet. Then I like to take the other side and I like to engage that side. Again, make my cotton pellet tight. Now, if you're using, you can, oh, I got a little bit of that gel. That gel is a little precarious there. Let's see another, darling. If you're using Neo MTA, this is even a bit quicker process because, of course, you take the mixing out of it. But we wanted to show the mixing, so you got a little bit more for me. That gel is a little bit messy. Doesn't quite mimic, but pretty good mimicking of the pulp. Let me just put it, yeah, just that little bit. I think we'll be good. All right, let's see. Seeing just a little bit. I gotta, that gel is like basically strawberry jelly on a tooth. You got a tiny bit more for me. I'll take that and I'll get this. And we want to make sure we don't have any residual MTA, of course, anywhere but where we want it. She's giving me just a little bit more in there. Like I said, I'm trying to cover up that little piece of gel so it looks pretty for you all, but you can only take fake teeth so far. So these are 2 gel teeth. You can see that one didn't get any gel mixed in. The one I did for you did today. But the goal is, the keys are 2 millimeters depth and making sure that the orifices are sealed. You want it to be like a skating rink in there. Okay, now from here, I prepped while she was doing that. So in the real world, and if we have time, we'll do that. I'll do my try on, and I have done a few zirconia crowns, so I can get that prepped while they're mixing if we're doing that. But the reality is, most of the time we use Neo MTA. If we have time, I will come back and do this. The other thing I wanted to show you, we're going to show you Neo MTA now, and I'm going to go back to my my burr. I'm going to check on my time here, make sure we're doing pretty good. So this is zirconia crown beside. So what we're going to do, this burr is a little forlorn, but what we're going to do is just do a little pulp, but this time using Neo MTA. So when I was trained on anterior primary teeth that you either didn't do a pulp or you do a pulpectomy. And I think the reason was the literature really did not support these ZOE pulponomies in anterior teeth. But I can tell you with MTA, particularly Neo MTA2 and Neo Putty, I can do these all day long, and the outcome is just fabulous. I'm just going back to I'm putting a chamfer, just putting my chamfer with this burr, doing it like I know how. And then, of course, if this were a real tooth, I would then be heading in with the slow speed, but it's not. So we're just going to say hypothetically that I have an exposure, and we know that we access primary teeth incisors by going more of a facial incisal route. So we're going to just do that. We're going to access that chamber. And let's just say that pulp, since it was an exposure, we expect it to be a little hyperemic, and we need to get down to that healthy pulp tissue. But we want to make sure that we don't go past the CEJ, because again, we're using MTA. So she's going to give me a little puff of air. And again, this would be copious irrigation if we were actually doing a real tooth with treated water. And this is how fast Neo MTA is. It is magical. So if the pulp looked good, I know I don't have to do pressure hemostasis very long. And if it looked questionable, I would want to know. Sometimes I peek and like, oh, let me see. Maybe we have to switch to a pulpectomy. But we're going to say that looks good. So we're going to go ahead and just make sure one more time, and then she's going to give me that MTA, and she's going to use just a tiny, tiny little bit. And this is why there's zero waste with Neo-MTA. This is really a game changer in our field because there just isn't waste, and it's also not messy, and there's not messy cleanup, and we can go straight to it. So then I'm going to put this in there, and these ivorine teeth are a little bit stickier than our other teeth, and then we're going to go back with the pellet. And you can use a damp pellet. I find oftentimes that just, you know, if you make the pellet tight, you don't even have to make it that damp. The Neo-MTA pulls its water and begins its process by recruiting fluid from the dental tubules and the pulp itself. So you can imagine if you don't do a good job making this seal with the pulp tissue, you know, what you might do is cause it not to set because you're not letting it recruit enough water and begin its process. And then at this point, of course, we're back to where we started. The pulp is treated, so we'll just quickly, ever so quickly, give ourselves just a quick little beautiful, we're switching our chamfer, exchanging a chamfer for a very beautiful feather margin. You'll see if I touch that zirconia crown next because it will spark. Got to be real careful about that, particularly in the OR. Most people have issues at the line angles, the distal lingual, and the distal facial. You know the line angles, mesiofacial, mesiolingual. And we want to make sure we don't have any sharp edges that could cause any catches or any issues with our crown. And then let's see how we did. Here's our try-in. We're going to try on our try-in. So we're going to check to see. And of course, there we have it. There is our try-in. And I'm going to check the time. We're doing well. So let's go ahead and cement this one, guys, so we can show them what we do. So a lot of people, because with ProRoot and some of the other MTA products, they felt that they had to basically put something over top of this, Vitribond usually, but you don't. So what Darlene's going to do, she's going to fill my access first. And again, normally it would be washing and drying this. And normally there would be gingival, give me a little bit more there, darling. Normally there would be gingival fluids and so forth that we would be handling with pressure hemostasis with a 2x2. I do not use hydroxyl, any type of medicament on the gingiva for hemostasis. So this is what it's going to look like. You just filled that chamber. Now it's going to unite with the cement in this tooth. Now this is very viscous, so it displaces, this is Biosim, it displaces any fluid that we might have. And we're going to push it down. I've got a finger, darling, I'm good. Sometimes she's trying to hand me this. You got to be careful using a pusher, but you want to wait 15 to 20 seconds before your initial cure, just to make sure you've given the dentinal tubules plenty of time to engage. And I like to make sure there's no rocks, no voids, no anything. And in the United States, we count seconds by saying 1 Mississippi, 2 Mississippi. So I do that in my head. Then we're going to tack cure. Now this is a pretty good size crown. It's not tooth D or something. So I normally will do 1 beep on the facial and 1 beep on the lingual. If you're going to err on your initial cure, I definitely err on the harder side. I hold the crown in place and then I just peel the cement away and make it. She's hesitant to use the section because she doesn't want us to not be able to hear. And then grab that floss. Let's show them how we do it. So normally, of course, well, sometimes I have the tooth beside prepped, but I would be cementing them at the same time. Normally, I'll hold the crown while she flosses and pulls through, or she'll hold it tight while we do this. And we'll check around one more time, make sure there's not any other loose cement. Never pull cement this way. And then finally, we'll do our final cure. And usually we practice with 2 curing lights. So she'll cure 2 on the facial, I'll cure 2 on the lingual. And we'll do a little bit and we're almost done with this. And then the final thing, we're not going to do this here, is we challenge the crown, particularly in the OR. If you're going to have a debond, you want it to happen while you're still right there. So we will challenge this by just blowing air and water and spraying a storm and doing all these things. But of course, normally 2 by 2, we would cement them together. But I just wanted to show that for you. All right, I'm going to check on my time, friends, and it looks like it is time for me to quit showing you these videos and go back to talking to you in person and see if there's any questions that I can answer for you. I'm going to, give me 1 second. Let me switch out of these loops, and then I can't wait to hear your questions. All right, I'm back. Somebody
Okay.
talk to me. Are there any
Yes.
questions? Okay.
Hi. Just quick questions because I think, thank you, by the way, for your really beautiful and exciting lecture. And would like to remind everybody that this lecture is being recorded and it will be available on the Saudi Society of Pediatric Dentistry website for everyone. And thank you again, Dr. Laree, for your informative lectures. And definitely we have, I'm sure, so many questions, but I'll just start with one main point. Uh, since I start using the MTA, I think I found 2 difficulties and you overcome them. Is exactly what would be the best mix, because I know a lot of people, they found some difficulties in mixing the MTA, and the questions that it always came up, what would be the perfect mix for the MTA to be used in Kalpani? We know that for indirect, we'll use a smoother one that can adapt to the wall and it can stick to the wall or to the floor better than the one that we use for the pulpotomy. But for the one for the pulpotomy, what would be the perfect mix, and what would be your advice for the mix, given that uh, we use it before we use the putty? The new putty, we don't have to worry
Mhm.
about the mixing since it's ready mixed. So that's
All
my
right.
first point.
So then you're right. The Neo Putty is magical. I mean, that is just, it is so great. And it is the perfect mix. You know, the perfect mix is hard to do when you're under the gun and, you know, you have a 3-year-old in the chair and they're tired of being there, and it's a lot of pressure for the dental assistants to mix it. But our team knows if they're going to err on one side or the other, it's better to have a harder mix versus a softer mix, because we want to make sure that we are able to really press it against that pulp tissue to get the antimicrobial benefit, the dental healing benefit. And sometimes with the gooier mix, it draws back a little bit, and I feel like there's opportunity to make greater voids in there. So with the harder mix, you can really push it down. Some people will even use an amalgam condenser to condense it, and that's a little bit hard for my taste. I don't want to go past the cotton pellet, but I find that that's the perfect mix for me. With great success, I should
Okay.
say, since I've used MTA, which, like I said, it's probably been 12 years, probably working on 13 years, I have had 2 pulpotomy failures. And I feel like I push the window a little bit more because it's such a good material. You know, I give a little bit of bleeding. Oh, it'll probably, you know, so I continue to push the window, which is probably why I've had 2 failures. But if you think about the thousands upon thousands of, I mean, 99.9% success rate with MTA.
Okay. Ah, that's a good point. The other question is how important is to use the water or the damp cotton pellets while you're packing the MTA? I know that you just mentioned that in your prep. If you can, would you kindly just re-emphasize? There are a couple of questions about that.
So when I'm extirpating the pulp, we use sterile water in the OR to rinse it and flush it and and do that, and we use treated water in our practice. But once I'm done, once the sterile, we put the cotton pellets in the autoclave, once the sterile pellets go in, if I can just use a plain pellet, I don't use a damp pellet, because it's the moisture in the gel for the Neo-MTA2, and it's the moisture from the body for the neo-putty that actually triggers the events that we're looking for in the ultimate set. Sometimes if the mix was a little bit dry with the Neo-MTA2, I'll use a little bit of a damp pellet. But honestly, with neo-putty, we use a dry pellet that we roll up very tight and don't even use the damp pellet for the neo-putty. Good questions.
Okay, now we have, I think, a resident in the Saudi board and the master's student and doctoral students who are attending these lectures. What would be your word for them? Because some of them are just getting into the practice, or they're still in training and they'll be in the practice. For my days, all days, I was using pharmacresol in Michigan. I mean, that was just a luxury of having the MTA. Now, MTA is more dominant than the pharmacresol and other alternatives. So what would be your words for the MTA and in general in pediatric dentistry for our residents and the graduate students?
Well, my understanding is in your country, you're even more particular about the medicaments that are allowed in your country, and even more discerning than we are in the United States. So I'm actually surprised that you were allowed to use formicresol in your country. I can tell you from being the president of the American Board of Pediatric Dentistry and the conversations that I have with people all over the world, I see a day coming where we will not advise to use formicresol. And the reason being is the results are so profound for MTA and for the environmental effects of formicresol. And so I think my prediction is that within the next 10 years, formicresol will be stricken from the American Academy of Pediatric Dentistry's reference manual. That's my prediction. So my advice for your young residents is just never use it, period. If you use MTA with good technique, it is equally cost effective, and you're not mixing ZOE on top of it, and your chair time is increased, or like the more chair, you decrease your chair time, giving you more chair time for other friends to see. And I just feel that I would not use it. When I teach at the dental school, I do not let anyone use anything other than MTA, and preferably neo-putty, because that way they can focus on other things that they need to focus on and allow the medicament to do what it's supposed to do.
Okay. My last, I mean, that's a really good question and good points for your trial, from your lectures and for our residents. And the last thing is there's always a questions come to the immediate restoration on top of the MTA. Personally, I use a lot of glass ionomer on top of it before I put any other materials. Some people, they put, as you mentioned, Vitrabond, or some people, they just go directly with the composites, and some of them, they just put the cement. So what is your input into that for having, what type of restorations on top of the MTA before you put the final restoration, whether stainless steel or zirconia or any other crown?
That's a very good question. So I get asked that more than anything else, and I'll tell you where it stems from. Back in the days where we were using ProRoot, and that was the only option we had for MTA, it washed out. When you wash the tooth, it would wash out. So that's why we were all trained to cover it. But the Neo-MTA and the Neo-Putty does not wash out, and you absolutely don't have to do that. So if you're crowning a tooth, you do not need to put anything on top of the MTA. Now, as you can see, I fill the chamber, that access point, because what I know from a microbiology standpoint is any space is bad space. And we don't want any voids in any portion of our restoration. That is setting us up for a less probable favorable outcome. So we want zero voids. So I fill the access with the cement. And if I'm doing a stainless steel crown, I fill the access with key tack. and then I fill the crown. The same situation. For composites, the literature says that you actually don't have to cover for the composites. For me, I do. And the reason why I do is because I use such a little amount if I'm doing, it's very odd to do a pulpotomy composite, but it does happen every once in a while. But if I'm doing an indirect or direct pulp cap, it's such a small amount, it would be easy for me to dislodge it and be unaware of that. So I want to make sure, because it's such a small little piece, that I have it right where I want it, again, to have that direct impact with the pulpal tissue or the dentin to help the dentin heal the pulp. So the recap is nothing over crowns. I use Vitribond before composites.
Okay. So thank you so much again, Dr. Laree Johnson, for your informative lectures. I learned a lot. Thanks for your presentation and for the demonstrations with the live prep, which is really helpful. By the name of the Saudi Society of Pediatric Dentistry, we would like to give you a small appreciation certificate from the society by the name of all pediatric dentists in Saudi Arabia, uh, to thank you for your time and efforts and for the knowledge and the lectures that you give to us tonight. And we would like to have you here in Saudi to visit us physically with your family. Really, I mean, we'd love
I
to
would
have you
love
here.
that. There's so much more pediatric dentistry we can talk about, and I'm so grateful. Thank you. It's been an honor to spend some time with you today. I really appreciate it, and I wish I could stay for the next lecture, but I think I better get back to work. You all have a great day.
Well, thank you. Thank you so much. Thank you.
Thank you. Bye.
Bye-bye. Okay. Well, thank you, everyone. And we really had a wonderful speaker, Dr. Laree Johnson. And I'm sure we have another wonderful speaker, Dr. Mazin Al-Qahtani. He's a graduate of the College of Dentistry at University of Dammam, where he's currently the assistant professor in the Pediatric Dentistry Division under the Preventive Dental Science Department. He obtained his doctorate degree in dental public health, which I'm biased to because I'm a dental public health as well, from Boston University in Boston in the United States. Dr. Al-Qahtani also completed his pediatric dentistry residency training program with a master's degree in craniofacial sciences at University of British Columbia and British Columbia Children's Hospital, Vancouver, Canada. He has, mashallah, both the American and the Canadian boards in pediatric dentistry. Dr. Al-Qahtani is a fellow for the Royal College of Dentists of Canada in pediatric dentistry and a diplomat of the American Board of Pediatric Dentistry. He is heavily involved in several clinical and didactic sessions at the college. He also a member of several committees and the head of the pool surveys unit at the university. Dr. Qahtani is currently working in several research projects to be submitted to international and local publication. His main research focus is around special healthcare needs patients and their access to dental care. So we would like, very impressive, mashallah, CV, and we would like to welcome Dr. Mazin. تفضل دكتور.
يعطيك العافية دكتور حسان. Thank you to the Saudi Society of Pediatric Dentistry for having me tonight to give this lecture about special needs dentistry, and also thank you to Dr. Johnson for that excellent presentation about MTA use in pediatric dentistry. When I was first contacted basically by Dr. Manal to give this lecture, the first thing that came to my mind is to give a lecture about special needs, as it's my always favorite topic. And the thing about talking about special needs is that always the audience expects something about management of special needs patients in our dental clinic, managing a medically compromised case from A to Z. And this actually what I was doing when I started giving lectures about special needs. I was assuming that every special needs has access to dental care, and I started lecturing about management of autistic kids in the dental clinic, management of cancer patients in our clinic. But then I realized that, well, we do have a problem in terms of accessing dental clinics for those special needs patients. So the topic today will be mainly about exploring the current status of special needs access and utilization to dental care in the kingdom. Also, we'll go over some numbers, global and local prevalence of special needs patients. Also, the future of those special needs kids in accessing and utilizing dental care in the kingdom, and to ask a question if we are meeting the needs, the dental needs of those patients or not. And then we'll close my presentation with some research areas that I think will be needed to explore in the future in the field of special needs dentistry. So when it comes to special needs, children with special health care needs definition, and if you go into the literature, we'll find many sources with different definitions for special needs patients. The most common one comes from the World Health Organization 2012. They define them as any child or any person who has a restriction or lack of ability to perform an activity in a manner within the range considered normal for a human being. The American Academy of Pediatric Dentists also defined them in 2014 as any child with physical, developmental, mental, sensory, behavioral, cognitive, or emotional impairment or limiting condition that requires medical management, healthcare intervention, and use of specialized services or programs. So as you can see, it's a very broad definitions. It involves those with very mild conditions, those with, let's say, with mild asthma, who only takes their medications once a month or maybe less than that, to those patients who are admitted in hospital for cancer treatment or transplant treatment. And the focus of this lecture is for those with more complicated medical conditions, those with multiple needs that really are missing in our dental care here in the kingdom. Before going into the core of this topic, we'll just give a few numbers about the prevalence of those children with special health care needs worldwide. And based on the GPD survey, which was done in 2015, 5.1 of all children are actually living with a special needs condition. The UNICEF in 2005 also has provided another percentage of those with 8.6, and then they changed their percentage in 2013 to 5.6. And the main reason for this inconsistency in terms of providing prevalence of special needs is that the definition is not consistent. So when the definition of this basically population is not consistent, we will end up with different reporting of percentages, whether in the kingdom or worldwide. So the WHO in 2018 suggested that 12.7 lives with special needs condition. However, only small amount of them, 0.4, actually have more complicated medical condition in the kingdom. And I was very happy when I found this report published by the General Authority of Statistics in the kingdom. It was, I guess, the first report about disability in 2017, and they're planning to do it every 5 years. So we would expect the next one to be out around 2022 or 2023. It has very detailed survey about special needs in the kingdom, and including small amount about questions about dental care for those children. So they found that almost 6.4% of all children are living with special needs conditions, highest being in Asir and lowest being in Najran. However, those with more complicated medical condition are only about 3% of the whole population. So it seems like it's not that high when it comes to percentage, but if you are someone who sees children on a daily basis, 10, 20 patients a day, you would expect one patient at least to show up with a more complicated medical condition that requires more consultations, more arrangement and treatment planning to provide the needed dental care. So it is still very significant to basically address the needs of that one person with a special needs condition. When it comes to the access to dental care worldwide, they always face the same barriers, whether in the kingdom or globally. So the barriers that they face basically is that they have a complicated medical condition, very significant and severe medical case. Also, they have to pay out-of-pocket amount in order to get the needed dental care. Also, they don't have enough coverage, insurance coverage, to cover their dental needs. And most importantly, the shortage of dentists in the area where the child with special needs lives. And this is also, and not only in the kingdom, but also when reviewing the literature, you will find this is one main factor. Every family with the special needs, they struggle to find someone who is trained and confident to see their child for dental treatment. Transportation from and to the dental office was also one important factor when it comes to providing dental care, and also the fear and anxiety from being in a dental office is also another important factor. So that was from the patient side, but when it comes to our side, we also found that there is a deficiency, let's say, in the pre-doctoral and postgraduate component of special needs in their training. There is not enough knowledge given for those students or residents during their programs, and therefore, once they graduate or finish dental school or pediatric program, there is basically they're unwilling to treat or at least see, examine, assess special needs patients. So this is our part of the equation when it comes to the access of those children to the dental care. So what's the current status of special needs in the kingdom? There is no nationwide, well-designed, multi-center study that examined the status of those children in the kingdom when talking about dental care. So whenever there's a child who has a special needs condition or a family with a special needs condition, their options either to go to government hospitals, Ministry of Health, Ministry of Defense, National Guard hospitals, any of those government hospitals, or they have to basically pay out of pocket and go to a private hospital, or they get the treatment abroad when they travel to get the medical treatment for that child. And how they get seen? Usually by direct communication, get referred by a medical colleague, or basically a friends or family. They just suggested the dentist who is sees the special needs patients, and they get that advice and go see that doctor. So not that much of options for those children with special needs patients in the kingdom. And who provides the dental care usually? Usually pediatric dentists, GPs, and some other specialties. And the most important questions comes, are they getting the needed dental care? Well, in order to answer that with confidence, we need research. Do we have research? The answer is no. We really don't have that strong evidence of research to say a valid statement that we can evaluate those the access of those special needs, and they have access or they don't have access. We don't know if they have access to the dental care in the kingdom. So we lack this part in Saudi. I really thank all those doctors who has been very active in researching special needs status in the kingdom, and I found many studies. But the overall, most of the studies, either there is a small sample size, either the sample itself, it's just focusing on one medical condition, or asking about the access. And there is a huge difference between access and utilization. I mean, every dentist, I guess, would be fine with examining a special needs patient in the clinic, maybe establish a very quick treatment plan. But the question, does the child really receive the treatment? And here it comes, the utilization. Most of the studies that we have only focus on accessing the dental care. Do they have regular checkup? Yes, but were they really receiving the treatment needed? We don't really know. It's not really clear. This is a study done by Dr. Shehri on persons with disabilities, found that almost 85% only sees a dentist if there is an emergency, and that's the only case. So that means 15%, around 15%, see their doctor on a regular basis. The access difficulty, as with the global picture, or barriers, they have basically the same barriers. Another study done by Dr. Balkhi in 2013 on individual with intellectual or physical disabilities found that 70 or 71% access dental care. So we are having an inconsistent results about access to dental care for special needs in the kingdom. From 15% to 70%, that's a huge difference. And I'm sure the sampling, the way the study was done, is made a huge difference. Dr. Murshid in 2011 did a study on mainly autistic kids, and found that almost 1 in 2 kids had no dental experience. So that was their first dental visit to the dentist. So this is already on the news. This is already getting public. The newspaper is talking about it. The special needs patients, they cannot find the trained dentist to see them in the clinic. It's not only in one article. If you just Google special needs and dentists, you'll be amazed by the amount of articles in the newspaper that's talking about special needs need for dental care. And obviously we have a problem. So we are mainly talking about the management of special needs, how we can get that patient's specific treatment. But the main problem is that, do those kids actually have access to get that treatment? And if they have access, are they utilizing that service? Are they getting that dental treatment, whether in the clinic, under GA sedation? We still have no answer for this question. But until we get that answer, I guess we need to work in a collaborative approach, medical part of this dental family community. We have to get together in a way to improve the access of these children, to make it easier for these children with special needs to get their treatment done. From the medical part of this equation, we need to work on improving the referral system within the institutions, ministries, hospitals, between hospitals. I'm seeing so many patients in the private clinic, and they get treatment or their medical treatment from another hospital. And when I ask about their medical history, they give you briefly the medical history. Of course, there are significant points in any medical history or that we need to focus on when seeing these patients, but it's not always provided by the parents or the family. So I find it difficult to get in touch with the physician in charge in the other hospital just to get his consultation about this medical case before proceeding with the treatment. Sometimes I had to call the hospital to get the cell phone number of that doctor, or email, wait for 2-3 weeks to get a consultation back, and sometimes it doesn't come back actually. They need basically the medical staff a continuous education to the medical care providers about the importance of dental health, to include a dental checkup as part of their medical checkup, and to get the dental providers involved in those medical teams in hospital, craniofacial teams, trauma team, cancer team, all teams that requires the presence of dental care providers. We need to be there on board. Also, as part of the medical part of this equation, the education for the patients and caregiver about the dental aspect of their conditions, explain the possible manifestation of some oral or some medical condition, oral manifestations. So increase basically the awareness of those families about their specific medical condition, and also have an updated list of special needs pediatric dentists handy with all these medical care providers in hospitals and institutions. And also, this is a study that was done back in 2017, evaluating the referral system between the medical and dental team. I found that in most cases, whenever a dentist gets a referral from the medical colleague, it's not very comprehensive, not very detailed, and it always requires a second consultation to get the full medical history about that patient. So maybe an improvement of the referral system, whether it's an electronic or written form of referrals, has to be there and addressed to improve those patients' access to dental care. From our side, as a dental care provider, we have to improve the undergraduate and postgraduate curricula. Knowledge and clinical experience are two important factors to give that resident, that student, the confidence to see a special needs patients, at least examine that special needs patients. Also to create a database for all dentists willing to treat special needs patients. And I'm sure that there is a database for all these dentists. And thank you to the Saudi Society of Pediatric Dentists for providing such a list of pediatric dentists who provide care for special needs on their website. So if you go to the Saudi Society of Pediatric Dentists and Google special needs patients or doctors, you will find the list of the dentists with the address, phone numbers in every city in the kingdom. And this is an excellent step by the Saudi Society of Pediatric Dentistry toward improving the access for special needs patients. Established a special needs clinic in hospitals and dental schools. And last year, we just opened the special needs clinic in Imam Abdulrahman bin Faisal University with access to GA for special needs patients. From our side also, maybe we need to work on community-based campaigns across the kingdom to educate families with special needs about their available resource for their special needs. That can be done by universities or sponsored by universities or ministries. From the family side of this equation, those families are always overwhelmed by the need of their special needs patients. That special needs, in many cases, and I'm talking about those with complicated medical condition, needs constant supervision all the time. And most of those parents would like to have raised their kids at home. In many cases, with a special needs child in the house, there is a changing in the family dynamics. And it ends up with having a child with a single parents household that leads to increased poverty. Increased poverty meaning that patients or family has to pay out of pocket. That means the child will not get the needed care. So it's our job to get them involved, maybe to educate them about the resources they can use to get their loved ones and access to dental care, and maybe guide them through the process, or one of the team can do that. And this is how the basically family dynamics can change. Marriage can be compromised when you have a special, of course not in all cases, but in many cases, marriage can be compromised. Employment also can be impacted for having a special needs patients, and all these factors, along with having to provide that child with the medical care needed, complicate the situation of the family in a way that they might forget that there is something needed dentally. From a community side, we need to share with those societies bodies involved in improving the quality of life of special needs, the resources that we have as a pediatric dentist or dentists, dental clinics that are willing to see those special needs. Maybe educate them about the list of dentists that we have and willing to see special needs patients. Include a dental checkup as part of their regular checkup and that bodies that are involved with the special needs. Maybe arrange in-house campaign, can be sponsored by universities or ministries toward those special needs and provide access for them through government hospitals. If government hospitals, as far as I know, are overwhelmed with the long waiting list of special needs, securing a fund if needed to get those special needs treated in a private hospital, or make some sort of collaboration between government and private hospital to provide the needed dental care. Also, they might collaborate and come up with a special needs registry, which has all the names of special needs in the kingdom, and that would be easier to access for dentists and also for those special needs families. So assuming that we had this all basically done in a way or another, medical dental family community, now the child have an access to dental care, utilizing dental care. So what is next? Usually what comes next is that transition of that child from being in a pediatric centered clinic into adult centered clinic. And that's very difficult part of that child's life, because he's going from being seen by a pediatric dentist, by a pediatrician, into a field where he's seen with other adults by another dentist or physician. In many hospitals, the way it goes, they have a transition team, a transition process, where the child before turning 18, let's say 15 or 16 years old, they start what they call the transition process, introducing that child and the family to the new dentist to be under the care, and also the physician to take care of that child. And usually the way it goes, the child starts seeing that dentist once a year, and then in the second year, twice a year, and until he gets adapted to the new environments, and then his medical and dental records gets moved to the new dental and medical offices. This is a big step toward making sure that the child does not end up without a dental care once he's turning to the age of 18 or 19, or his dental work is out of the scope of pediatric dentists. So what should we do? Basically, education provided to the family and the patients, set the time for transition, usually 2-3 years before the child turns 18, but let's say there is no dentist willing to see that special needs patients when you start the transition process. So the answer is just keep that child under your care. And if that child needs any other specialty, any other specific treatment, an endo RCT treatment or prosthetic treatment, so we'll get that specialist or consultant involved in your clinic to provide the care for that child. This is the transition process. It's an advanced kind of process or stage for special needs, and of course having them access the dental care comes as the first priority. So in Saudi, what about research? What about special needs research in Saudi? We lack, as I said in the beginning of this presentation, a nationwide, well-designed, multi-center studies to evaluate and assess their situation. All what we have is single studies done in one city, one hospital, maybe a small sample size, a specific medical condition, but none is nationwide has been conducted. When we plan to do a special needs study, I would suggest that we have a consistent definition for children with special healthcare needs and stay with that definition across all studies that would be published in this field of special dentistry. Also, we have to differentiate and make that very clear in our studies, the difference between accessing and utilizing dental care. And the difference is very, very clear and important whenever conducting a study in such a field. Well, in summary, we have 6.4% in average children with special healthcare needs lives in Saudi. 50% based on our limited literature, limited studies done in Saudi, unable to access dental care. We need, of course, a multi-approach to help make a better future for all these kids. Collaboration, medical, dental, family, community collaboration is mandatory. We need to work also on the transition process in our hospital institutions, and as long as there is a huge lack of research, there is an excellent research opportunities, and I guess the field of special needs dentistry is one of them. I guess that's all, Dr. Hassan, for my presentation, and I'll be more than happy to receive questions.
Well, thank you. Thank you very much, Dr. Mazin. Very impressive and mashallah, very nice presentation. And again, that's a combination of the specialties, the dental public health and the pediatric dentistry, mashallah. You are qualified to be the leader in this field. Again, and as we mentioned, that's a big manpower questions or lectures. But before I go to that, to the questions part, I would like to remind everyone that these lectures of Dr. Mazin and the others are all recorded at the Saudi Society of Pediatric Dentistry website. So you can go back and it's available to everyone. Now, before I go into something further, I would like to have a general questions for you, Dr. Mazin. You mentioned in several points, that there's a solution to increase the access. And do you think, because that's a big question with the graduates, do you think the numbers of pediatric dentists available in, to treat those special health needs, children with the special health needs here in Saudi, are enough or needs to increase the numbers of the graduates and the graduate program in pediatric dentistry to fulfill the needs? How would your, from your experience, mashallah, how would you feel into that, especially in planning of the grad programs?
I think, Dr. Hassan, the issue is not the number of pediatric dentists or the number of dentists, let's say. It's basically the willingness of those pediatric dentists and dentists, GPs, to see special needs patients. I know many GPs who see special needs patients, treat them, and collaborate with pediatric dentists to provide the care. So it's all about how willing the pediatric dentist to provide or to accept to see special needs patients and to consult if consultation is needed, and to provide the environment, whether in the clinic or under GA, to provide the care for the child. So it is more than a number of special. Yes, we know that we still lack numbers of pediatric dentists in the kingdom, but it's all about is that pediatric dentists willing to go and take a step forward and accept the special needs patients. So it's all about, I guess, willingness to see that child.
That's an excellent point. And I know from my humble research that also the insurance company should have some sort of acceptance and treating those children in their payment with the private dental practices more willingly to increase their access and to have give them that special situation and treatment. And again, this is not only the problem here or the a barrier here in Saudi. I think all over the world that this group of children needs more attention and acceptance from pediatric dentists. So from your point of view, just another point, from your experience, if we have a plan for the next 5 years, I know we have people here with us now today, from a resident to a consultant to a decision maker. If you have like only 5 years to change something about the acceptance and access, what would be the number one or the first step to take to improve that acceptability and access for children with special health needs here in Saudi?
This is an excellent question, Dr. Hassan. So I think number one priority would be to improve the curriculum of the undergraduate and postgraduate programs, to start with those resident students from step one, that we have special needs patients out there waiting for you to get them the needed dental care, and also involve them in a clinical experience, really seeing patients in hospital, and like adapt them with the environment of special needs care from early on in their training program. So that will be my number one priority: education, clinical experience, resulting in competent pediatric dentists and dentists willing to see special needs.
Sure. That's a really fair point. I totally agree. I cannot add in that. That's excellent. I have a question from the audience. It says, Dr. Mazin, in your opinion, how can we improve the collaboration between the private practice and the government bodies for the care of children with the special health needs?
Well, another excellent question, and well, that's and very difficult to answer. I mean, private hospitals, as far as you know, they're private. All what they're looking for is just what comes at the end of the month in their pocket. And government hospital, they're overwhelmed with their patients. So unless there is some sort of financial agreement between government and private hospital, you take our patients, you reduce our waiting list, and you will be repaid this amount of money. Other than that, I don't think, unless it comes from, of course, higher management, of course, that will be solved. And other than that, things will stay the same without really having this comes as an order from, let's say, a Minister of Education or Minister of Health.
So you think that the financial incentives from the government to the private practice would help that collaboration?
Absolutely will do. Absolutely will do. I mean, the private hospital, they have no problem in opening their GAs or times for special needs patients, whether for dental care or medical care. But there has to be something in return.
Okay. And there's a question I always love to ask, since we have residents, I'm sure, with us today or tonight, and we have graduate students. And I know that you have, from your experience, mashallah, what would be your words on this regard, on treating children with special health needs as a future pediatric dentist to them?
Well, for special needs, if they're willing, basically, once they graduate to see special needs patients, I would advise them to practice dentistry in hospital where there is basically where it is a hub for special needs. An example would be a specialist hospital in Jeddah, in Riyadh, in Dammam. They do see a lot of special needs patients, and they main priority on the list of their dental patients are special needs patients. So you got the education, you got the knowledge about special needs patients. Now you need to go and maybe practice special needs dentistry. It is very easy to maybe read about special needs patients, treatment planning, but when it comes to practicality, it's quite not that easy. You need the collaboration, you need consultation, you need to find space for those special needs patients. So any resident, students who is basically willing to go and basically practice in the field of special needs dentistry, there is a huge lack of special needs dentists in the kingdom. I mean, I do see them daily by daily in my clinical practice. Special needs are waiting for you. They need you, and it's just a matter of time until you're out there.
Well, thank you so much, Dr. Mazin. Literally, this is by all means a vital topic, especially in pediatric dentistry. I would like to thank you by the name of the Saudi Society of Pediatric Dentistry for your time and efforts, for your valuable information, and for your nice lectures, Dr. Mazin. This is a certificate of appreciation from the society to Dr. Mazin Al-Qahtani, and by the name of all pediatric dentists, all the members of the Saudi Society of Pediatric Dentistry, we'd like to thank you, Dr. Mazin. Shukran lak.
Thank you, Dr. Hassan, and thank you to the Saudi Society of Pediatric Dentistry. Very happy to be with you tonight.
We're honored to have you. Shukran lak.
Shukran.
And thank you for attending. And thank you for all the attendance. And thank you for the organizing committee. And thanks for the Saudi Society of Pediatric Dentistry having me as a coordinator to give me this opportunity to coordinate these two wonderful lectures by two wonderful speakers. Thank you all. And inshallah, we'll see you in another events of the society. Thank you all.